morning, everybody, and welcome to the webinar. My name is Kate Tilbury, and I'm an accredited CBT therapist and clinical supervisor at iESO Digital Health. This morning, we will be talking about increasing access to CBT to foster resilience and emotional well-being for perinatal women and postnatal women. And we're going to start off briefly by looking at some of the challenges, which I'm sure many of you will be aware of, for accessing services for these women. And we'll be going on to look at the services and provision around, and then thinking specifically about what CBT is. Moving on to specifically the service that I work for, iESO Digital Health. It's quite a novel service. I'll be explaining the theory behind it and the research behind it. And we'll be closing with a case study. All confidential data has been anonymised, so it is safe to share. Okay. So current challenges that I'm sure we are all familiar with is that actually it's not uncommon for people who are in their pregnancy or postnatal to be struggling with emotional difficulties. So 1 in 5 women and 1 in 10 men will be affected by an emotional disorder during this time. And unfortunately, only 50% of these difficulties will be detected, and thus people won't necessarily be receiving the evidence-based help that is available to them. This can obviously have quite a significant impact on people, on their relationships with significant others, and particularly their own children. Also, it can affect their functioning in their own personal life and with work. It might have some financial implications also. Another barrier is that we know that while services will prioritise those people that are pregnant or postnatal, there can be some quite significant waits for evidence-based treatment, particularly in traditional face-to-face services. There can also be psychological barriers as well that might prevent somebody from seeking help, and that might be the perceived stigma that they perceive for opening up about some of the distress and difficulties that they're having. They also might be concerned about their children being taken away from them if they were to admit that they were struggling. It can also be very difficult to access appointments, particularly if you're based somewhere quite remote and you perhaps don't have a car and the public transport might be quite infrequent. It might also be quite costly as well. Also, some people will be keen to maintain some degree of normality. They'll be wanting to continue working. So finding appointments that are outside of working hours can be an additional barrier. Most of you here, I'm sure, will be aware that actually in 2014, NICE guidance did incorporate some questions from evidence-based validated tools to help with detection of depression and anxiety. And these questions are brief, so the idea is that they can be asked in some of the time-restricted appointments that you may have with people. If people do answer positively to questions about depression and anxiety, you're then faced with the choice about what service is most appropriate. There'll be IAPT services or there'll be secondary care. And just a brief bit about IAPT. It's a government-led initiative started in 2008 to enhance access to evidence-based treatment. The idea was that all people across the country should be able to access evidence-based treatment, and that they should be able to get exactly the same treatment as somebody in a different part of the country. And IAPT was set up for mild to moderate mental health difficulties. The reality is that most IAPT services will be treating people where actually the severity is higher than what it was initially set up for. And that will be determined by some of the outcome measures that we'll be looking at later. I think the key distinction is that when it comes to thinking about risk to self or others, and that includes unborn baby or children that might be present, if there is any risk and if there are any psychotic symptoms, then that certainly wouldn't be appropriate for a primary care service such as IAPT, and that's when you would be thinking about secondary care. Of course, you can consult with a GP as well or refer to a GP to make a further assessment. And most services, primary care or secondary care, will have a lead contact that you can speak to as well if you're unsure about suitability. IAPT services have different steps, and they have step 2, which is for the milder end of severity. So this is guided self-help, which is evidence-based as well. And what that entails is that somebody will do a lot of the work themselves with self-help materials, and they'll be prompted by a coach in terms of making some of the changes and gains that they wish. If somebody's scores are a bit higher than mild, then they'll actually be entitled to step 3 treatment. and that's with a CBT therapist, and they'll have one-to-one treatment, and that treatment may go on for longer, and it'll be far more individualised to the patient and their difficulties. So, brief recap on IAPT and what it was set up to do. It wanted to increase access to services, and it also wanted to make sure that actually people were having evidence-based treatment in the hope that this would improve clinical outcomes and recovery, and this also increased patient choice and satisfaction. It also wanted to make sure that nobody was prevented from accessing treatment, and that included people from all socioeconomic backgrounds. What was needed to happen and was identified was that there'd need to be high quality training providers around the country as well to upskill current therapists to become CBT therapists. In terms of how we might detect whether somebody is suffering with depression or anxiety, and if indeed they are pregnant or postnatal, there are a variety of ways that we can assess that. So if somebody has been referred by a GP or healthcare professional, then we will have their referral notes to refer to. We do also accept self-referrals, so we ask people to complete a self-referral form, and that will be really important to look at before we meet with them, and it will tell us what they see as a problem in their own words and how they're defining and describing that. We then have a triage appointment, which is our opportunity to gather further information about the difficulties. And we will use the validated measures that IAPT have designated to understand whether depression or anxiety is a significant problem, or whether in fact both are troubling the patient. In terms of specifically understanding whether somebody is pregnant or postpartum, we ask them to denote that when they first register for our service, and they are also prioritised in terms of their care. The PHQ-9 is a measure for depression. It's got 9 items, and specifically the final question will understand whether somebody is at harm towards themselves or others. The GAD-7 is a 7-item measure, and it helps us understand whether worry and anxiety is a significant problem for the person. The phobia scales will help us determine whether there are specific anxieties relating to social situations, panic and agoraphobia, and whether there may be a specific phobia such as tocophobia, for example. The WASA is the Work and Social Adjustment Scale, and it helps us determine how the emotional difficulties are impacting on somebody's functioning across work, personal life, hobbies, and just managing their home and taking care of cooking and normal duties that they might have. But there's also an alcohol screening measure that we'll use. So let's think about what is CBT. I think the first thing to say is you may all be familiar with CBT. It's widely used, and that's due to its large evidence base for its efficacy as a treatment for depression and anxiety disorders. Let's just start with understanding human behaviour, and that is that we're all prone to evaluate things. And right now, looking at this picture, you'll be evaluating whether you like the picture, whether you dislike the picture. You might be evaluating how many stars there are, the depth of the colour. And some of these evaluations will be based on prior experiences and learning in terms of associations, perhaps with the night time and the dark, and whether that's comforting or discomforting. And of course, as human beings, we constantly evaluate ourselves, and we evaluate others, and we also evaluate how we are perceived in the minds of other people as well. Eck was the founder of CBT, and he identified a range of thinking styles which have been further corroborated by evidence over time as being present amongst all of us. So we will all have thinking styles that we will use at times. And you probably might look at some of these thoughts here: must, I'm bad, should, too insecure, unworthy, not good enough. And you yourselves might identify with some of those. What research tells us is that actually when we're depressed or anxious, we will have more of these types of thoughts. And you can imagine that if you have more of these types of thoughts, there are going to be consequences to that. And emotionally, we're going to feel worse. And behaviourally too, we're going to act in certain ways. Of course, just recognising that these are common and helpful thinking styles can be really helpful for people to notice at first and normalise that actually this isn't something that just they're suffering with, and that actually there are treatment that can help with these. If we take a look at a basic cognitive behavioural model, you'll notice it says event, and then cognitive appraisal, and then emotion. And what most of us will do before we have CBT or have awareness of this cycle is we will think that an event itself has led to an emotional reaction. So let's imagine you've had a falling out with one of your best friends, and perhaps they've been rude to you and angry, and they've said some hurtful things. It's likely that you're going to feel upset and possibly angry about that, and it's likely that you might conclude, they've made me feel this way. What we fail to do is appreciate that in between that, we've made some interpretations about what has happened. And depending on how we interpret that situation will make a difference to how we are feeling emotionally. So if we perceive that they've never really liked us and they've always been waiting to say this to us, then we're going to feel quite hurt and dejected by that. Behaviourally, we might decide to avoid them, or we might decide to be a bit more distant with them when we see them. And this, of course, will have further repercussions. And cognitively, we might reinforce the idea that, yes, they've not made any effort with me, they don't like me. So CBT helps us spot that actually in every situation, we are understandably interpreting those situations in a way that meets with our previous understanding about those situations. If we take another example of an exam or assessment, the thoughts might be, I'm no good at exams, I'm going to get too anxious. That thought in itself will trigger a physiological arousal. That physiological arousal will be taken in turn as evidence. See, I am even anxious now, and the exam's ages away. Therefore, our behaviour change is likely to be one of two things. We might avoid revising altogether in the belief that there's no point anyway, or we might overcompensate, and we might do lots of revision and preparation. And this can be just as destructive as avoidance, actually, because it might mean that we sleep less, we might eat less, and we might see less of our friends. And that will have an impact as well in terms of the quality of revision that we do. So then understanding behaviour, and we can see from this diagram that there's two paths there. And it's understandable that over time, we create shortcuts in terms of how we respond. And it becomes our default response. But sometimes our default response might be understandable at the time how we came to do that, but might be also unhelpful for us. And we might need to create new behavioural patterns of responding, which again is something that we can look at in CBT. It's also worth recognising that control can sometimes be the problem. And the more we try and control the situation, the more futile the situation and our efforts can become. So if we take worry, for example, and let's imagine somebody's worried, it's a pregnant lady, and they're worried about the complications at birth. They might try and control that situation and do all the research possible to see what kinds of problems might there be. They might actually end up, though, with far more negative scenarios than they initially had, and left with more what-if worries about what might go wrong. Turning now to internet-enabled CBT. In iESO, what we do is we're offering therapy via written typed conversation, and that happens in a secure online environment. It's a live one-to-one appointment that's been scheduled at a designated time that fits with both the patient and the therapist. There's strict clinical and information governance, and there's now approved patient pathways and recovery metrics. And we do, as I say, have an evidence base. Some of the things that we know about internet-enabled CBT, and this is from research that supports this, is that actually there's what we call an online disinhibition effect. So what we frequently get reports from therapists and patients is that actually the anonymity has served to make disclosures far quicker than what it might normally be if somebody was sat face-to-face with somebody. Thinking about why it might be effective as a modality, well, we're combining CBT, which we know has a strong evidence base. And we know CBT is effective because there is a strong emphasis on collaboration and patient learning. And it has good recovery, and also it maintains that recovery, and relapse prevention is minimised. Then if we take into account visual learning and the research behind visual learning, we can see that it's been demonstrated to be more efficacious than oral learning. So within iESO Digital Health, by having people type out their feelings, thoughts and behaviours, and also by reading it back in their own time, that's being processed in a different way to traditional therapy. What it also means is that people have access to their transcripts for life. So during the course of therapy, they can refer back to a session. And once their therapy has ended, they can refer back to their sessions. And that's really important because there is some research that suggests within a 60-minute face-to-face session, we might remember only about three key things. So in 2009, there was a paper published in The Lancet based on our service, and it was a cohort of depressed patients. And what this enabled us to see was that we did have proof of concept in our delivery, in our model. So at 4 months, we could see that people were recovering, and that was substantially different between those people in the control group, and that actually that effect was maintained at 8 months. Interestingly, we found that 6 sessions was generally what was required, which is significantly lower than what we would have predicted, particularly given that severely depressed patients can actually really struggle sometimes to benefit from psychological interventions, and yet we found that those were the ones that benefited most. And people were reporting that actually it was easier to talk in the comfort of their own home, in their own environment, and without somebody looking directly them in the face. As a provider, we've been providing therapy for 15 years, and we've been an IAPT provider since 2012, delivering both Step 2 and Step 3. And what's interesting is that it's the same therapist that does the triage and both of the steps, Step 2 and Step 3. So what might normally happen is you might have somebody does an assessment with you, and then you have to wait some time, and then you'll meet with a different Step 2 therapist. And if you have to be stepped up, you'll have a different therapist again. So one of the advantages with online therapy is that you'll be attached to the same therapist throughout the triage and the Step 2 and Step 3 work. We've got over 300 therapists working for us now, and they're all based across the country. We have an ongoing recruitment, so it means we can be very flexible to the needs of the patients. So if we suddenly have more referrals coming through, it means that we can manage our wait times. We also provide mandatory supervision and free CPD events as well. Now I'm going to show you some slides of what the site actually looks like. And again, this is our training site, so there is no confidential data here. This is the landing page or the home page for the patient. So when they log in, what they can see initially is that they've got a message waiting for them from their therapist. They can also see that there's a scheduled appointment for them, which they simply need to click on join. And they can see that the outcome metrics are ready for them to fill in before the session. This is an example of the secure chat, the therapy session itself, and the indentation denotes whether it's the therapist or the patient speaking. Also at the bottom of the grey bar, it will show when somebody is typing, so it prevents overlapping and over-typing with each other. Goals are an important part of CBT, so we have a designated goals area, and clients are given ownership over changing the scale on the continuum for how much progress they're making, and then they can receive some encouraging prompts from their therapist as well about the progress that they are making. And here we see the messaging system. So this is asynchronous messaging. So this happens away from the therapy appointment. And again, this is quite unique and doesn't typically happen in traditional therapy. So actually, if somebody has some clarity they need about one of the homework tasks, or if they have an important message that they need to get to their therapist, they can send that and they know that they'll get a response within 48 hours from the therapist. This is an example of what the outcome measures look like. So they are automated on the system and they get sent out before every single session. So we track things like the mood and the anxiety. We're keen to see how comparable we are to other services, and consistently we see that we are very comparable to face-to-face services. So you can see the yellow bars is iESO and the blue bar refers to other IAPT providers. So we can see that a high proportion of people complete treatment, which shows us that it's an accessible and acceptable treatment for people. We can see that people are recovering and that DNA rates are lower. And we also, within our patient experience questionnaires at the end of treatment, have valuations from people about how they perceive the therapy to be. And as you can see, the mean PEQ score is 21 out of 24. So we get generally very good feedback from people. In terms of what people say are the benefits, they like the anonymity that this service provides. It feels less pressure for them, it can be discreet, and they can have the therapy anytime, anywhere. So most of the appointments that we offer are actually in the evening between 6 and 9 p.m. And of course, you're probably familiar that a lot of other services won't provide those times, nor on weekends. Text in itself forces order and logic. It documents a narrative. It embeds and reinforces learning. And as I've mentioned, transcripts are available. So when we're thinking about benefits, there are far-ranging benefits, but thinking particularly about ladies who might be pregnant or postnatal, mobility is a big issue, and actually childcare can be a big issue, and financial implications as well. So to be able to stay at your own home to access therapy is really important for people. It requires no travel. Of course, other people might feel that they're too busy to have therapy but may really need it, and so it can happen outside of their working hours. You don't have to worry about frequent transport. You don't have to worry as well if you're quite socially anxious, because sitting in front of somebody can be excruciating if you're quite socially anxious. And of course, there are reduced waiting lists as well. What we're keen to do is we're keen to actually not only be comparable, but we're keen to continue improving as a service and improving our outcomes. So we submit data monthly to the HSCIC, and we constantly look to see how we're doing and how we can improve. So our in-house tech and development teams have actually created what we call a dashboard. And this provides us with very detailed information about the disorders that we treat, about how effective we are at the disorders that we treat. And it also allows us to drill down for each individual therapist that delivers treatment for us to have a look at what disorders have they treated, which disorders do they tend to treat better, what their recovery figures are like, what patients say about them in terms of the patient experience questionnaire. This, of course, will inform not only supervision that we have with these therapists, but as well our CPD arrangements that we put in place throughout the year for people. Thank you. That's the end of the webinar, and I'm very